Welcome to the deep dive. Today we're going to tackle a really key topic in pediatric cardiology, especially for your revision, Tetralogy of Fallot. You might see it written as TOF.
That's right.
We've got the revision notes right here, and our plan is basically to pull out all the high-yield stuff you need to know about this specific congenital heart defect. Make it clear, make it memorable.
Absolutely. And TOF is a big one. You need to know it because it's actually the most common cyanotic heart defect in newborns.
Yeah.
Affects around, 2,000 to 3,500 births, something like that.
Wow, so pretty significant.
Yeah. And the name itself is a clue, right? Tetralogy, tetra meaning four. That's your first memory hook. It really revolves around four key abnormalities.
The classic four. Okay, let's list them. A ventricular septal defect, or VSD, then pulmonary stenosis, an overriding aorta, and finally, right ventricular hypertrophy.
Got it. Those are the cornerstones.
So let's use those as our guideposts as we dig into this.
Sounds good. So, definition first. Tetralogy of Fallot, it's a congenital heart defect, meaning present from birth, and it's defined by those four features you just listed.
Okay.
But often, the underlying developmental issue is what we call an anterior malalignment of the conal septum.
Conal septum. Can you unpack that a bit?
Yeah, think of it like the wall that separates the outflow tracts of the heart during development. If it doesn't line up quite right specifically, if it's shifted forward, anteriorly kind of sets the stage for those four abnormalities to develop.
I see. So one initial misalignment leads to the VSD, the overriding aorta, and the pulmonary stenosis, which then causes the hypertrophy.
Exactly. That's the cascade. And clinically, you'll typically start seeing signs around 1 to 2 months after birth.
Okay.
Now, it's not always just those four things. Sometimes there are, let's say, associated anomalies. A right-sided aortic arch is seen in maybe 20% of cases.
Oh, interesting.
Yeah, and you can also sometimes find an atrial septal defect, an ASD, in maybe 8 to 10%. You have TOF plus an ASD, so people would call that Pentalogy of Fallot, penta for 5, a little memory aid for you.
Pentalogy, right, good one. And you often see genetic links with these sorts of congenital conditions, don't you?
Very much so. Chromosomal abnormalities are found in about a quarter, maybe 25% of TOF cases.
And any specific ones to flag up?
Yeah, the big ones are trisomy 21, that's Down syndrome, and also 22q11.2 microdeletions. Those are quite strongly associated.
Okay.
And the end result of all these structural changes, clinically speaking, is cyanosis, that bluish tinge to the skin because the blood isn't getting oxygenated properly.
Right, that makes sense. So we've got the definition and the key features. What about the why, the etiology? Do we know what actually causes TOF?
Well, like a lot of congenital conditions, the exact cause isn't pinned down definitively. It seems to be multifactorial, meaning it's likely a mix of genetic factors, some predisposition, and environmental influences acting together during pregnancy.
We've already mentioned the genetic links, like Down syndrome and the 22q11 deletion.
Right. Those are significant associations. But there might be other more complex genetic factors in some cases, too. It's not always linked to a known syndrome.
And the environmental side, what sort of things are we talking about?
Well, the notes mention several potential risk factors during pregnancy. Maternal smoking is one, alcohol use during pregnancy is another, and also exposure to certain medications has been implicated.
Okay. That flows nicely into looking at the risk factors more systematically. Maybe we can group them.
Good plan. So you could think about maternal influences first.
Yeah.
That's where we'd put smoking, alcohol use, and those certain medications during pregnancy. Maybe think SAM, smoking, alcohol, meds, just as a quick mental checklist for those maternal environmental risks.
Sam, I like it. Okay, what's the next category?
Genetic factors. So this includes having a family history of congenital heart defects in general. And then, as we keep saying, those specific genetic conditions or syndromes, especially Down syndrome, and 22q11 deletion syndromes.
Got it. And the third category?
Other environmental factors. Exposure to certain infections during pregnancy, for example, has also been suggested as a possible contributor. It just highlights how sensitive that developmental period is.
Definitely. Okay, so definition, etiology, risk factors covered. Now, let's get into the core of it, the pathophysiology. How do these four abnormalities actually mess with the blood flow?
Right. This is crucial for understanding why the symptoms happen. Let's break down the hemodynamics, the blood flow dynamics for each one. First, the VSD, the ventricular septal defect.
The hole between the ventricles.
Exactly. It allows oxygenated blood from the left ventricle to mix with deoxygenated blood from the right ventricle. So think VSD is mixing.
Okay, mixing. What's next?
Pulmonary stenosis, or PS. This is a narrowing, either at the pulmonary valve or just below it, in the outflow tract. This restricts blood flow going from the right ventricle out to the pulmonary artery, heading towards the lungs.
So less blood gets to the lungs to pick up oxygen.
Precisely. And the severity of this stenosis can vary quite a lot, which really dictates how cyanotic the baby is. Think PS equals obstruction to lungs.
And that obstruction must put a strain on the right side of the heart.
It absolutely does. And that brings us neatly to the fourth feature, right ventricular hypertrophy, RVH. Because the right ventricle has to pump much harder against that resistance, that narrowed pulmonary outflow, its muscular wall thickens up, it gets bigger. So RVH to use muscle work.
Makes sense. We skipped number 3, though, the overriding aorta.
Ah, yes, the overriding aorta. So normally the aorta arises completely from the left ventricle. In TOF, because of the VSD and that septal malalignment, the aorta is positioned sort of over the VSD. It overrides the septum, meaning it receives blood from both the right ventricle, which is deoxygenated, and the left ventricle, which is oxygenated. So the blood leaving the heart through the aorta to supply the body is already a mix. Think overriding aorta, mixed blood to body.
Okay, I can picture the plumbing now. VSD causes mixing, PS limits lung blood flow, the aorta picks up mixed blood, and the RV works overtime, causing RVH. So the main consequences overall are?
Well, you've got that mixing of oxygenated and deoxygenated blood happening within the heart. Then, because the PS limits flow to the lungs, less blood gets oxygenated in the first place. And finally, the overriding aorta sends this poorly oxygenated mixed blood out systemically, leading to reduced oxygen supply to the body's tissues. And that's what manifests clinically as cyanosis, that blue discoloration.
Got it. Now, if a baby presents with cyanosis, TOF is a prime suspect, but it's not the only cause, right? What else should be on our differential diagnosis list?
Really important point. You absolutely need to consider other cyanotic congenital heart diseases. Key ones include transposition of the great arteries, or TGA, where the aorta and pulmonary artery are switched.
Okay.
Then there's truncus arteriosus, where there's only one single large vessel coming off the ventricles instead of two. And pulmonary atresia, where the pulmonary valve is completely sealed off, or atretic.
So cyanosis is the big flag, but you need investigations to pinpoint the exact cause.
Definitely. Careful workup is essential.
Speaking of how common TOF is, let's touch on the epidemiology again. You said it's the most common cyanotic defect.
Yes. Among the cyanotic defects, it's number 1. Overall, it accounts for maybe around 10% of all congenital heart defects.
And the numbers in the UK?
The estimates are around 3 to 5 cases per 10,000 live births. So roughly 1 in 2,000 live births. It's not super rare in the world of congenital heart disease.
And those genetic links are worth repeating.
Absolutely. Remember the strong association with trisomy 21 Down syndrome and 22q11 microdeletion syndrome. Others mentioned in the notes include DiGeorge syndrome, fetal alcohol syndrome, maternal PKU, fetal hydantoin syndrome.
Right.
And that link to 22q11 deletion is important. TOF is considered part of the CTCH22 spectrum of anomalies associated with this deletion.
CTCH22, I remember hearing that. Is that a helpful mnemonic?
It can be. TTCH stands for cardiac defects, abnormal facies, thymic hypoplasia, cleft palate, hypocalcemia, and the 22 points to the chromosome. TOF is the C, often. That's a good way to link the genetics.
Okay, useful. Right, let's move on to how patients actually present. What are the classic clinical features we should look out for?
Well, the most obvious sign, as we've said, is cyanosis. That bluish color of the skin, lips, nail beds. You'll often notice it gets worse during activities that increase oxygen demand, like crying or feeding.
Okay, cyanosis, what else?
Difficulty breathing is common. Often they'll breathe rapidly to chypnea. You might also see poor feeding, and consequently poor growth or failure to thrive. Their body just isn't getting the oxygen nutrients it needs to grow well.
Makes sense. And you mentioned something earlier, TET spells.
Ah, yes, the TET spells. These are really characteristic of TOF. They're also called hypercyanotic spells. These are sudden episodes where the baby becomes profoundly blue, very distressed, and might gasp for air.
What triggers them?
Usually things like crying, feeding, straining, like having a bowel movement, or even just waking up. Anything that causes a sudden drop in systemic vascular resistance or an increase in pulmonary vascular resistance can trigger one. They're serious and need prompt management. Think TET spell, sudden blue crisis.
Definitely one to remember. What else might we find on examination?
Over time, due to chronic low oxygen levels, you might see clubbing of the fingers and toes. The ends become bulbous.
Right.
Delayed development can also be a feature. When you listen to the heart with a stethoscope, The classic finding is a harsh ejection systolic murmur,
Where do you hear that best?
usually best heard at the upper left sternal edge. It's mainly due to the turbulent blood flow across that narrowed pulmonary outflow tract to pulmonary stenosis.
Okay, a murmur. Anything else on exam?
You might feel a prominent pulsation along the left side of the sternum, a peristernal heave, which is a sign of that right ventricular hypertrophy.
Mm-hmm.
And another interesting auscultation finding can be a single-second heart sound, S2. Normally, S2 has two components, aortic and pulmonary valve closure. But in TOF, because the pulmonary stenosis is significant, the pulmonary valve closure sound, P2, is often very soft or completely absent. So you only hear the aortic component, A2. Single S2, missing P2.
Single S2. Good tip. Anything else?
Well, the underlying physiology is a right-to-left shunt. In really severe TET spells, the child might even lose consciousness briefly. And on imaging, which we'll get to, that boot-shaped heart on chest X-ray is a classic sign.
The courant sabot.
Exactly, the French term, heart in a woody shoe. It's quite memorable. Oh, and don't forget that possibility of a right-sided aortic arch we mentioned earlier.
So, to recap presentation. Usually around 1-2 months old, presenting with cyanosis, maybe difficulty feeding, and that key ejection systolic murmur. And watch out for TET spells.
It's a good summary.
Okay, so we suspect TOF based on the clinical picture. What investigations do we need to confirm it and figure out the details?
Right, the workup usually starts with some basics. A chest X-ray is a common first step.
Again, we're looking for
that boot-shaped heart. The apex seems lifted up because of the RVH, and the pulmonary artery segment might look concave because of the pulmonary stenosis. You might also see if the aortic arch is on the right side and check the pulmonary vascular markings. They're often decreased, meaning less blood flow to the lungs.
Okay, X-ray first. What about an ECG?
An ECG, electrocardiogram, looks at the heart's electrical activity. In TOF, it typically shows signs of that right ventricular strain and hypertrophy, so you'll likely see right axis deviation and evidence of RVH. Sometimes a right bundle branch block pattern too.
But the main diagnostic tool is often the echo, right?
Absolutely. Echocardiography, an ultrasound of the heart, is really the gold standard for diagnosing TOF. It gives fantastic visualization.
What can it show us specifically?
It can directly show the VSD, assess the severity and location of the pulmonary stenosis, confirm the aorta is overriding, and measure the degree of right ventricular hypertrophy. It gives you the whole picture. And in most cases, the information from the echo is enough to plan the surgical repair.
So often you don't need more invasive tests.
Not always for initial diagnosis and basic planning, no. But sometimes more advanced imaging is helpful.
Like MRI or CT.
Exactly. Cardiovascular MR or CT can give very detailed anatomical information, which can be useful for surgical planning, especially if the anatomy is complex, or for assessing the pulmonary arteries in detail. They can also assess for things like pulmonary hypertension.
Okay. The notes also mention a hyperoxia test.
Ah yes, the hyperoxia test or nitrogen washout test. This is sometimes used in newborns who present with cyanosis. You give them 100% oxygen to breathe. If the oxygen levels in their blood rise significantly, it suggests a lung problem. If they don't rise much, it points more towards a cyanotic heart defect like TOF where they're shunting.
I see. And can TOF ever be suspected before birth?
Yes, antenatal ultrasound can sometimes pick up cardiac abnormalities. Features might suggest TOF, although it can be difficult to diagnose definitively before birth. Seeing a normal aortic root size might make TOF less likely, apparently, but detailed fetal echocardiography can certainly raise suspicion.
And preoperatively, you might use MRI or CT again.
Yes, preoperative MRI or CT angiography can be really valuable for getting precise measurements of the right ventricular outflow tract obstruction and mapping out the pulmonary artery anatomy, which helps the surgeons plan the best repair strategy.
Okay, comprehensive investigation strategy. Now the crucial part. Management. How do we treat Tetralogy of Fallot?
The definitive treatment is surgical repair. This is typically open heart surgery, usually performed in early infancy, maybe between 3 to 6 months, though timing can vary.
And what are the goals of the surgery?
The main goals are twofold. 1, close the ventricular septal defect, usually with a patch. 2, relieve the pulmonary stenosis. This might involve widening the pulmonary valve itself or enlarging the outflow tract below the valve, sometimes using a patch there too. Think surgery, closed VSD, plus open pulmonary outflow.
Okay, complete repair. But what if a baby is really sick right after birth? Too small or unstable for the full repair?
Good question. For those neonates with severe cyanosis or complex anatomy, sometimes a palliative procedure is done first. This isn't a full repair, but aims to improve oxygenation temporarily.
Like what?
The classic one is a shunt procedure, like the Blalock-Taussig shunt, or BT shunt. This creates an artificial connection, usually using a small tube graft, between a systemic artery, like the subclavian, and the pulmonary artery. This gets more blood flowing to the lungs.
So it buys time until they're ready for the full repair.
Exactly. It's often part of a staged repair approach. You might do the shunt first, let the baby grow and get stronger, and then do the complete intracardiac repair later, maybe around 6 months to a year old. Sometimes initial palliation can even be done via cardiac catheterization, like stenting the outflow tract.
Are medications used as well?
Yes, definitely in certain situations. For newborns who are very cyanotic and depend on the ductus arteriosus staying open for pulmonary blood flow, we use prostaglandin E1 infusions. Prostaglandin keeps that duct open.
Okay.
And for managing those acute TET spells, medications are crucial. Beta blockers like propranolol can help relax the muscle spasm in the right ventricular outflow tract, reducing the obstruction. Sometimes morphine is used for sedation and to decrease respiratory drive, and oxygen is given, of course.
So the management really depends on the age and clinical state.
Absolutely. Let's break it down. Neonates. If they're very blue, immediate stabilization is key. Oxygen, keeping them warm, IV access, and starting that prostaglandin E1 infusion. Elective repairs usually aim for within the first year, ideally after the first few months when outcomes might be slightly better. But symptomatic babies might need intervention much earlier, possibly with a shunt first.
Okay. Then infants.
If they have less severe obstruction, surgery might be planned electively around 3 to 6 months. While waiting, you focus on keeping them, preventing dehydration, treating any iron deficiency anemia, which can worsen cyanosis, and crucially, educating parents about managing test spells. The knee-chest position, which increases systemic resistance and promotes pulmonary flow, oxygen, keeping calm, and when to seek urgent help. Sometimes daily propranolol is given prophylactically to prevent spells.
And what about adults with repaired TOF?
Thankfully, many people reach adulthood now. Early mortality after repair is low. They need lifelong follow-up, though. We monitor for long-term issues. An elevated hemoglobin in an adult can be a sign of chronic cyanosis, perhaps due to residual problems, and that's associated with poorer long-term outcomes.
What about pregnancy for women with repaired TOF?
That's a really important area. For most women with repaired TOF, pregnancy is generally well tolerated. However, there is an increased risk of complications compared to the general population, particularly things like ventricular arrhythmias or developing heart failure symptoms.
So they need careful monitoring.
Definitely. Specialist cardiac and obstetric care is essential. Sometimes monitoring a blood test called NT-proBNP can help assess the heart strain during pregnancy. But for most, vaginal delivery is considered safe and is usually recommended.
It sounds like the surgical approach has to be really tailored to the individual.
Absolutely. The specific anatomy of the VSD, the outflow tract, the pulmonary arteries, coronary arteries, it all influences the exact surgical strategy. It's not one size fits all.
Okay, that covers management really well. So after all this, what's the overall outlook, the prognosis?
Well, the good news is that with timely and appropriate surgical repair, the prognosis for children born with TOF today is generally very good. It's really been a success story in pediatric cardiac surgery.
How so?
The advances in surgical techniques, intensive care, and medical management over the last few decades have just dramatically improved outcomes. Most individuals who have the repair can expect to lead relatively active, normal lives with ongoing follow-up.
That's fantastic to hear, but you mentioned follow-up. Does that mean there can still be long-term issues?
Yes, that's the crucial caveat. Even after a successful repair, especially one done years ago, there's potential for long-term complications. That's why lifelong follow-up with a cardiologist specializing in congenital heart disease is so important.
What sort of complications are we talking about?
Things like residual defects, maybe the VSD patch leaks a bit, or there's still some pulmonary stenosis. Arrhythmias, or abnormal heart rhythms, are quite common long-term. The pulmonary valve, even after repair, often ends up leaking significantly over time. That's pulmonary regurgitation, which can strain the right ventricle.
So that can lead to?
Right, ventricular dysfunction or enlargement over time. And sometimes further surgeries or catheter interventions are needed later in life to address these issues. Maybe replace the pulmonary valve. Think long-term follow-up, monitoring for residual issues and valve problems.
So while the prognosis is good, it's not necessarily cured forever.
That's a good way to put it. The initial surgery dramatically improves survival and quality of life, allowing for near-normal life expectancy in many, but ongoing surveillance is key. Just to put it in perspective, before effective surgery, survival was grim. Your notes say only about 11% survived to age 20 and 3% to age 40.
Wow.
Whereas now, with current surgical treatment, the 30-year survival rates were reported somewhere between, say, 68% and over 90%, depending on the specifics.
Yeah.
A huge improvement.
That really highlights the impact of the surgery. You mentioned pulmonary regurgitation and residual obstruction are common problems.
Yes, those are probably the most common hemodynamic issues seen long-term after TOF repair. That leaky pulmonary valve, the regurgitation, can cause the right ventricle to dilate and eventually fail if not addressed. And sometimes the outflow tract can narrow again, stenosis. These often require intervention later on, maybe a valve replacement.
Okay. Let's focus specifically on those complications then. Can we list the main ones to be aware of?
Sure. So shorter long-term, you can see arrhythmias, both atrial and ventricular. Pulmonary valve issues, either regurgitation leaking or stenosis narrowing. Residual VSD, aortic root dilation, the base of the aorta can stretch over time.
Right.
Ventricular dysfunction or failure.
Any others?
There's a lifelong increased risk of infective endocarditis, which is an infection of the heart lining or valves, so good dental hygiene and antibiotic prophylaxis for certain procedures are important. And as mentioned, the need for further interventions, either catheter-based or repeat surgery, is quite common as the person grows or as valves wear out.
What about development?
Unfortunately, some children, particularly those who are very cyanotic or had complications around surgery, may experience neurodevelopmental delays. And while rare, sudden cardiac death can occur in adulthood, usually related to arrhythmias or severe RV dysfunction.
The notes also mention specific post-operative complications.
Yeah, in the immediate period after surgery, low cardiac output syndrome can be an issue. And longer term, besides the valve issues and RV dysfunction, sustained ventricular tachycardia is a serious arrhythmia risk. Also, studies show that even 20 years post-surgery, exercise capacity might be reduced compared to healthy peers.
It really emphasizes the need for that specialist lifelong care.
Absolutely. Regular checkups, imaging like echo or MRI, ECGs, sometimes exercise tests, they're all part of monitoring for and managing these potential complications proactively.
Okay, well, this has been an incredibly thorough deep dive into Tetralogy of Fallot. Let's try and quickly summarize the absolute key takeaways for revision.
That's good.
So remember, TOF is defined by those 4 core features: VSD, pulmonary stenosis, overriding aorta, right ventricular hypertrophy, think PROVE, pulmonary stenosis, RVH, overriding aorta, VSD, if that helps.
Good mnemonic. And remember, it's the most common cyanotic congenital heart defect, often presenting around 1-2 months with cyanosis and that ejection systolic murmur. Watch out for those dangerous TET spells.
Investigations usually start with chest X-ray, looking for the boot-shaped heart, and ECG, but echocardiography is key for diagnosis and planning.
Yep, and management is primarily surgical repair, closing the VSD and relieving the pulmonary stenosis, usually in infancy. Shunts might be needed for palliation first in severe cases. Prostaglandin E1 is vital for duct-dependent neonates.
Prognosis is now generally good with surgery, but lifelong follow-up is essential to monitor for complications like arrhythmias, pulmonary valve problems, especially regurgitation, RV dysfunction, and the potential need for further interventions.
Exactly. Don't forget the genetic links, especially trisomy 21 and 22q11 deletion, CTCH22.
So for you, the listener, as you're prepping for the MSRA, really focus on linking the pathophysiology, how those 4 defects cause the cyanosis and the clinical signs. Understand the management principles, especially the surgical goals and the handling of TET spells.
And keep those visuals and mnemonics in mind. PROVE, the boot-shaped heart, single S2, TET spells, they really help things stick.
Definitely. And on that note, if you are looking for more top-notch resources to help you absolutely smash the MSRA,
You should definitely check out pastthemsra.com.
and for some excellent free materials to get you started, head over to freemsra.com.
Great resources on both sides.
Well, that brings us to the end of this deep dive. Thanks so much for joining us.
Our pleasure.
And we'll catch you on the next one.